would like to thank you to give me the opportunity to discuss about the findings of the reality trial on behalf of all my friends and colleagues, and first of all on behalf of Gabriel Steg, who is the principal investigator of this international trial, as well as Grégory Ducrot, who was the French PI of the study, and Dr. Juanate from Spain, who also coordinate the trial in terms of investigators in Spain. My name is Tabassome Simon, and I'm a clinical pharmacologist in Paris, France, and I had the honor to be the scientific coordinator of reality trial. The reason why we tried to settle this randomized trial was that, as you know, anemia is a very common feature in patients with acute myocardial infarction, and it is associated with worse prognosis. And whether patients should be transfused and the way they should be transfused as a liberal or a restrictive strategy has been very much debated without a clear evidence to which strategy would be best, because there is a lack of trials in this setting, while there are in other settings such as surgery or patients with gastrointestinal bleeding. But in patients with MI, the physicians do not have an evidence-based medicine on which strategy would be best in terms of avoiding, of course, a major coronary events. And so what we did is to look to the data available, and the observational trials were not conclusive. The randomized trials that existed in other settings usually excluded patients with MI, and there were very few trials in patients with MI, actually only 2, with a very sample size. And they had conflicting results. In one trial, there was a trend towards a higher number of events with the liberal strategy, and the other one exactly the opposite. So clearly, there was a need for a randomized trial in a larger sample size in order to evaluate this question. Reality has had the aim of answering the question regarding the non-inferiority of the restrictive transfusion strategy in patients with MI and anemia. And the question was whether the restrictive strategy was non-inferior in terms of events, but less costly. And so we looked to the incremental cost effectiveness ratio at 30 days with MACE as the effectiveness criteria. The trial was an international trial performed in 35 sites in France, but also in Spain. It was a open label randomized trial, and the 2 arms were a restrictive strategy in which patients had to be transferred if the level of hemoglobin was less than 8 or 8 grams per deciliter. And in the other arm, the liberal arm, the transfusion was given as soon as the hemoglobin was 10 or less. And the target level in the liberal arm was 11 grams per deciliter. We had calculated the sample size of the patients according to what we have had in a previous observational registry in France. It's a nationwide registry called FAST-MI, in which we had a higher level of MACE, and defined as death, stroke, recurrent MI, emergency revascularization, as to being 15% in the liberal strategy and 11% in the restrictive strategy. So we had calculated a sample size considering the margin, the upper bound of the margin for the non-inferiority to be at 125. We had calculated that we needed more than 630 patients in order to answer that question. And the question was whether the restrictive strategy is non-inferior in terms of MACE, but less costly. And so we looked to the incremental ratio for the cost effectiveness, ICER, at 30 days, with MACE considered as the effectiveness criterion. And the primary outcome of the trial was at 30 days, but we follow the patients until 1 year. And so the results that we presented here at ESC was at 30 days. So we randomized 666 patients in the trial, 342 in the restrictive strategy and 324 in the liberal strategy. The patients were quite old. Their mean age was 78 years old, and they were in the majority male patients, more than 56%, and 2/3 of the patients had a non-STEMI. There were not differences in baseline characteristics in the patients between groups. And when we looked to the number of blood unit transfused, the number of transfusion were not different. Patients had, when they were transfused, they had the same mean of units transfused. But overall, the restrictive strategy obviously had much less blood transfusion. Actually, we found a reduction of more than 55% reduction in the overall number of blood units transfused. So in terms of blood, there was a high reduction in terms of supplies. And when we looked to the primary outcome of efficacy, which was MACE, we had 11% of patients who had MACE at 30 days in the restrictive strategy and 14% in the liberal strategy. So the relative risk was 0.79 in favor of the restrictive strategy, with the upper level of the confidence interval, which was 1.18, and which did not reach the level of margin that we had chosen before, which was 1.25. So that means that we met both the criteria of non-inferiority in the per-protocol analysis, as well as the intention to treat analysis. So we demonstrated, in terms of efficacy, the non-inferiority of the restrictive strategy in reducing MACE. And then we looked to the economic, medico-economic analysis, and as I said, in the incremental cost effectiveness ratio at 30 days, and we found that it was negative, with 33,000 euros saved per MACE averted. And we also analyzed the joint distribution of costs and MACE, and we found that the restrictive strategy had an 84% probability of being dominant, which means that being both saving money, so less costly, but also improving outcome. In terms of safety, because that was also an important issue, there was no difference in the overall safety between both groups, restrictive and liberal. But what was very important, the overall safety was around 11% in both groups. But when we looked to the each component of the safety, we found two significant reduction, both in terms of bacterial infection in favor of the restrictive strategy, but also in terms of acute mild respiratory distress syndrome, which was also lower in the restrictive strategy compared to the liberal. So overall, the study found the non-inferiority of the restrictive strategy in terms of effectiveness in reducing MACE, a reduction, an important reduction in blood supply, less cost in the ICER, negative ICER, with 33,000 euros saved per MACE, and an overall safety for the restrictive strategy, with actually fewer infections and fewer acute respiratory syndrome, distress syndrome in patients with a restrictive strategy. What we found, of course, is we met what we had hypothesized, which was that we found that the restrictive strategy was non-inferior. But it would be nice to also look, we didn't have the power because the study was not designed in order to show the superiority or not of the trial, of one strategy versus the other one. So it would be nice to also see and have some data regarding the superiority. And there is a trial which is ongoing to look to that. So for us, until we have the final results in terms of superiority, we could say that these results suggest highly, as I said, indeed, they suggest highly that the restrictive strategy is at least non-inferior, safe, and also has a high probability of being both cost-saving and reducing MACE. I think, as I said again, the trial, before we did this trial, there was really a clear equipoise, and there was a very wide variations in the way physicians practiced and did transfusion in their patients, just according to their habits or to their personal belief in patients with MI and anemia. And I think this trial have given them some evidence-based medicine in a large sample size trial, which was designed for this specific target population. And we have an answer to their question, at least, as I said, the fact that doing transfusion is costly. It needs logistical issues, we have to have blood supplies, etc. So it's not an easy task. And the trial clearly shows the non-inferiority of a restrictive strategy in which you can safely spare blood products and still have a non-inferiority in terms of MACE and together a better cost for the hospital's income. So I think this is a clear message for physicians.